Yeah,
Cool.
now it's got
Nice.
it.
Yeah. So, hello everyone. I am so excited to take this lecture on nephrology and urology. So, this is the first class of AMC by Dr. Gupta. That's me. So, let's start it. I'm gonna be very brief and crisp, and you guys are most welcome to ask me the questions in the last if you have any questions. And we'll also be uploading this recording on our website, so you can watch it later. And our students will also be given the lecture, these PDF notes of the whole lecture, so that you can read through. And I prefer, I would recommend you guys to make your own notes. Looking at the slides, just keep on writing the things I'll be telling you guys, because we can't include everything in the notes. It's your own notes that are printed in your brain when you are taking the exam. You'll capture those moments when you are writing or when you're reading. So it's better to make your own notes. That's why I wanted you guys to have your own notebook and pen. So with no further delays, let's start the lecture. In renal system, there will be multiple cases. Different cases will have different histories. So most common cases are UTI, stone, CKD, BPH, discharges, incontinence. So if any question, any MCQ have symptoms like the patient presented with fever with chills, any abdominal pain, lumbar pain, or altered sensorium in old age, sepsis, these cases are towards urinary tract infection. And if there is a pain on the lumbar region radiating to the groin area with nausea, vomiting, severe pain, and spasmodic pain, that's more towards stone, so renal stones. And if a patient is a diabetic patient, hypertensive patient, and now presenting with edema, anemia, and fatigue, hypertension, so this is a typical history of CKD. Okay. And the cases with the benign prostatic hypertrophy, BPH, these cases will have the history like urgency, hesitancy. We'll divide these symptoms in irritative and obstructive symptoms, so that you can relate and memorize. But these are the symptoms of BPH. And the next is discharge. In discharge, you can have hematuria, cloud urine, hematospermia, pyuria. These cases are not very common, but yeah, hematuria is most important. I'll be discussing this as well. Incontinence, you'll have one question from incontinence. I'll be covering that as well. So incontinence, stress, urge, and different type of incontinence we'll be talking about in the end of the slides. And testicular pain, etc. So let's start with the situation. If a patient comes to you with the symptoms of fever and lower urinary tract symptoms, what should be your first investigation of choice? Sorry, I showed that already. Yeah, comment below. What should be the first investigation? Yes, so the first investigation would be urine dipstick. Urine dipstick, and the second is urinary MCS, microscopy and culture sensitivity. So what these tests are, because in India, in our countries, we rarely use dipstick, and we always go with urinary MCS. So dipstick is an office test in which this is a stick. We'll dip it in urine sample. In emergency or in GP clinic, we'll dip it in the urinary sample, and after like 30 seconds, 1 minute, 2 minutes, 3 minutes, different readings will be there with different colors. For example, if you look at this pink color, and it is, for example, it's showing proteins, so you match with these colors and you can tell how much proteinuria the patient is having, or the bilirubin. So this is the first point of care test that you can predict. It can tell you about a lot of things like leukocytes, blood, nitrites, showing UTI. If your sample, the dipstick is showing nitrites, then it's typical for UTI. And other tests like sugar, ketone, pH, bilirubin, specific gravity, etc., are also being noticed by dipstick test. So the next test is urinary microscopy and culture sensitivity. In microscopy, MCS, I'll be saying. So for MCS, there are different samples you can collect for MCS. like we want sterile sample. We don't want contamination, because then the culture results will be different. The contamination is there. So it should be midstream clean catch. So when the patient will be passing urine, we have to collect the middle sample of the stream, not the initial one. Initial one is for chlamydia. So if the patient wake up in the morning and we collect the initial sample, urine sample, that is for more like infective disease like chlamydia, tuberculosis, we collect the first sample. But for the urinary tract infection, we collect MC like midstream. And if the patient is having a catheter, then we have to like clean catch, and suprapubic in kids with retention. So different methods are there. We are not going to talk about these details because these are not important. You just know the concept that the clean sample should be tested. So first of all, physical appearance, you can look at color, clarity, and odor, because color can tell you about a lot of things, like is it like concentrated urine, patient is in dehydration, or if the patient, the urine is turbid, that shows that is infective. And the odor, like urinary smell, different things. But the question will be telling, in question, you'll be having more focus on microscopic and chemical features of MCS. For example, if you have proteinuria, how much proteinuria is there? If you're having glucose, ketones, nitrites. Nitrites are typical for urinary infection. In microscopy, you have to look at the cells, cast, sediments, crystals, and most importantly, culture. Culture is most important, like what sort of bacteria are growing. So, for example, I'll tell you a crisp thing. Urinary infections are most commonly caused by gram-negative bacteria. Why? Because our gut is full of gram-negative bacteria. Gut negative. So this is a mnemonic. Gut is full of gram-negative bacteria. So females, when they are cleaning their anal opening, and the urinary tract can be infected, or newly wedded couples, the urinary tract infections are most common because the infection goes from anal cavity to urinary tract. So most of the urinary tract infections are gram negative. And in old age, when the females are postmenopausal, there is so much dryness in that area that the infection can go through the dry area, and the patient can have urosepsis. And yeah, so E. coli, Klebsiella, Proteus, different kind of infections. And these infections, UTI will be covering in infectious disease class. So not going in much details, but yeah, this is the MCS you have to predict. So in culture, there'll be bacteria growth, and then we check the different kind of antibiotics, like which antibiotic is working, which is not. And the antibiotics that are working, we have a score called MIC. This is minimum inhibitory concentration. So this is the minimum amount of drug that is inhibiting the bacteria. So lesser MIC means more effective is antibiotic. So that is the significance of MIC. And next is like different kind of imaging techniques in renal system. We can go for X-rays, ultrasound abdomen, and IVP, intravenous pyelography. But this is not so common these days because we have CT-KUB and renal angiogram, cystoscopy. So these are the tests. We can also go for MRI and so more. So this is the situation, guys. Read this situation and make up your mind, like what's the impression and all the questions. Just try to read through the question. Okay, so what is the impression? What's the impression, guys? Comment. Yeah. I think you guys saw my my next slide. Yeah. So renal stone is your impression. And what is your best next investigation? Tell me. Okay, CT KUB. CT. Yes. Okay, CT KUB. Anybody else? Anybody with X-ray or ultrasound or any other investigation? Okay, there are some gurmeets, ultrasound, very good. Okay, so guys, this is a typical case for renal stones. The patient comes with this stance, like holding one side of tummy, and the pain will be going to groin area, nausea, vomiting. So this is a typical history and presentation of renal stones. Why I specifically added indinavir? Because most of the renal stones can be picked by X-ray or CT KUB, but indinavir stones are hugely missed by these investigations. So best next investigation is ultrasound abdomen in this case. And the management will be discussing in the renal stones in next slide. So different types of renal stones are there. Most common is calcium oxalate or calcium phosphate stones. Most of the times due to dehydration, renal tubular acidosis, hyperparathyroidism, calcium malabsorption, etc. So these are the calcium stones. The calcium and phosphate combines and precipitate in the renal kidney, kidney, and they make the stones. They are 80% of the types. These are calcium oxalate. The next one are the struvite stones, who are magnesium ammonium phosphate. So it is very difficult name to memorize, like this formula is quite difficult, but just remember these stones are made with infection, and the infection is with the different organisms which produce ammonia from urine. So when ammonia is produced, it combines with magnesium phosphate and forms struvite stone. And this is a typical present picture of struvite stone. It's a big staghorn calculus. So it's a big staghorn calculus covering all the pelvis of the renal pelvis. So it's associated with infections. It is 10 to 15% of the cases UTI with Proteus, Klebsiella, Pseudomonas, all gram-negative infections, all gram-negative bacteria are there. Next is uric acid. Uric acid stones are also not so common. Up to 10% cases are there. The people who are eating red meat, gout, and hyperuricosuriasia is there. And in uric acid stones, there's a very good combination to have uric acid stone. It is beer with mutton. So red meat and beer, it precipitates uric acid stones most of the times. So just be aware. And rare cases, cysteine, in the cystinuria cases, you can have cysteine stones. So if we have the picture, like how do they look under microscope? So all these stones we talked about, calcium oxalate, struvite, and uric acid, and cysteine, we'll be discussing about the features. So X-ray, the calcium is there in both the stones, and these are radio opaque. So we can go for X-ray abdomen or CT KUB to pick these. Okay, the uric acid stones are radiolucent on X-ray but are visible on CT. So all these stones can be picked on CT KUB. And now if we look at the microscopic pictures of these stones, just look at the name, calcium oxalate. This X is like envelope. So the picture under microscope will be envelope shaped. And the struvite stones, I told you these stones are made when there is infection, and when there is infection, people die. So these stones look like coffin lid. So when people die, and in Christian people, if you don't know about coffin, coffin is the box where they keep the dead bodies. So coffin shaped crystals are there in struvite stones. And uric acid is very sharp, and if you look at the U, you can remember with rhomboid shape, and it is sharp needle shape. So this is the uric acid stone. And cysteine sounds like 6, so it is hexagonal stone. And you don't have to memorize the causes much, but you should have a brief idea like how these stones are made or how they are looked. So these notes are more than enough for your question point of view. So the management, most of the stone cases are managed conservatively. So first of all, we'll go for investigations, as I already discussed, X-ray abdomen and CT KUB. We have to do the both of these tests, because in follow-up, if we have already seen the stone in X-ray, then we can follow up with the subsequent X-rays. If we pick the stone just in CT-KUV, there is no use of repeating X-ray on follow-up. So we have to follow up with CT-KUV. So do both these tests, but never do these tests in pregnant, and no need to do in India associated stones that we discuss in questions. In those cases, we go for ultrasound. Indenovirus associated stones are small and non-obstructive, so can be missed on X-ray and CT. But if the symptoms persist, then you can go for contrast CT if the symptoms are there. So no for NCT-KUV. So ultrasound first, and then contrast CT we can go for. Now comes to the treatment. Treatment is correct dehydration. I'm not saying hydration, because there is a difference between hydration and correct dehydration. Most of the times, what we do, we just give fluids to the patient, even if he's not dehydrated. So that's not good, because patient is already having AKI and fluid, or sometimes there is so much flow to the kidneys because of the stones. And if the patient is not dehydrated, that can cause further kidney damage. But we definitely have to correct the dehydration. So correct dehydration and manage the pain. And now the pain management can be done by NSAIDs, but this is also like double-edged sword, because NSAID will decrease the PG mediated pain, so pain will be improved. And when there is a stone obstruction, the blood flow to the kidneys is increased, and these NSAIDs will transiently decrease the GF glomerular flow to the kidneys, so helping with some pain relief. But don't give too much NSAIDs, because that can cause further AKI. So apart from dehydration and analgesia, one of the best drugs is tamsulosin. Tamsulosin is 0.4 milligram. It is a selective alpha-1 blocker, which dilates the ureter. So it dilates the ureter. So if there is a small stone, it can pass through easily. So, but there is a contraindication of this medication, that is CKD, CLD, orthostatic hypotension. Why? Because, as I told you, it's selective alpha-1 blocker, and it relaxes the smooth muscles. So it relaxes the blood vessels as well and cause hypotension. So in patients with CLD, hypotension, and CKD, it can cause adverse effects. And next is, and also this drug is a first line treatment for BPH, we'll be discussing later. So next is, once we treat the pain and patient is going home, we ask the patient to strain the urine, and whenever he passes the stone, just bring it back to the lab so that we can have a look under microscope type of crystals and what type of stones are these. So if it is not passed, then we have to repeat the follow-up X-ray or CT KUV in 4 weeks. Most of the stones up to 5 to 7 centimeters, 5 to 7 mm, 60% passes within 6 weeks with the above management. But we have to give patients some red flags. Red flags are most important, because you should know when we need to involve the urologist. So these are the indications for urology refer. You don't have to poke the patient if any of these are present. So if the stone size is more than 7 mm, stone not passed even after conservative management, single kidney, and pre-existing kidney disease, because we can't take risk in these patients, stone passed but ongoing bleed. Okay, so we have to go for further testing, cytology sample, and we have to refer to urology. If there is urinary tract infection and there is stone, so both things are going simultaneously. And if the pain is not managed with conservative medications and patient is still in severe pain, you have to involve urology. And anuria is, anyways, it's a very big thing. If a patient is not passing any urine, then he definitely need urology. So when we refer the patient of stone to urology, urologists have 3 options for the patient, what kind of operation he can offer. So first is laser lithotripsy, second is extracorporeal shock wave lithotripsy, and third is percutaneous nephrolithotomy. I'll be talking a little bit detail about all these procedures, so listen carefully. First is laser lithotripsy. Laser lithotripsy and ESWL, both these procedures are day care. Day care means the patient will be admitted and will be discharged in the same day. So these are bit simpler procedures. So let's just talk about laser lithotripsy. In laser lithotripsy, we go from urethra and go to ureter, and wherever is stone, we break it and get it out from the urinary tract. So laser lithotripsy is a slightly invasive, not too invasive, but yeah, it's like catheter type thing. So it is most common procedure that has been done by urologists. Stone anywhere in urinary tract, in calyx, in ureter, urethra, doesn't matter. Rigid or flexible scopes from urethra to ureter, then flexible laser to fragment. And after this procedure is done, we have to leave a stunt in situ for 2 weeks because the stone fragments will keep on going down and it can further precipitate pain if stunt is not there. So we put DJ stunt for 2 weeks. What are the advantages? It covers whole tract, stone up to 2 centimeters, and you'll get the stone right away and you can send for further testing, and it is widely available. But the risks are the stump symptoms, because once you have something in your genitalia, it can be irritating for you. So stunt symptoms and rarely ureteric injury, because these scopes are quite soft. And disadvantages are sometimes need multiple procedures and stunt is bothersome, as I already talked. Second is ESWL, extracorporeal shockwave lithotripsy. In this, we do this is the procedure. Just have a look, because just after reading, it can be confusing sometimes. So what we actually do, this procedure is done for the stones in renal pelvis. For example, the staghorn, struvite stones. So but if the size is up to 5 to 10 so renal pelvic stones up to 5 to 10 size. So this is called lithotripsy, and we deliver shock waves, either ultrasound type shock waves, to fragment the stone from outside. And it is rarely used in acute settings. What are the advantages? It is minimally invasive. There is no insertion of any scope or anything down there. It is well tolerated and no stunt needed. But the risk is pain and bruising, because it goes very fast, and it can cause hematoma around kidneys. And as there is no stent, those stone fragments can cause obstruction and sometimes hematuria. So these are the risks. And it is less effective in obese patients, definitely, because if there is a thick layer of fat between the lithotripsy and the stone, it's not gonna touch the stone anyways. It is expensive, poor outcomes with lower urinary tract stones, and it is contraindicated in pregnancy and not widely available. So both these procedures for daycare, the patient will be admitted and discharged the same day. Now there comes the PCNL, percutaneous nephrolithotomy. So it is an invasive procedure. The surgeon make a 2 centimeter incision to reach the renal calyx from upward with the nephroscope. He look at the stone, he break it there with minimal force under USG guidance, okay, or with laser. So we break the stone after looking at it. But as we are making an incision and doing an invasive procedure, the patient will be admitted for at least 2 days unless there is some complication. So advantages are excellent access to stones and better success. But risks, bleeding, it can injure the pleura, causing pneumothorax and renal damage as well. But it cannot reach the ureteric stones, because how deep you can go with this scope. And patient gets admitted for a few days, so morbidity is high and need experienced surgeon. So these are the procedures we can do in stones. Okay, so are we clear so far? Happy with the lecture? You want me to pace up or slow down? Thank you, Anubhav. Thank you. Okay, so we'll just continue the class. I hope you're learning. Okay, so yeah, so this is the next situation. Read the history and make your impression. Yep. Any answers? Yes, yes. Great. Very good. So yes, this is a typical case of renal cell carcinoma, and the investigation would be next investigation would be, as the patient have already had ultrasound, will be going for CT, contrast CT. In this case, there is a quadruple phase contrast CT. So let's just talk about renal cell carcinoma. Most of the renal cell carcinomas are incidental. The patient doesn't have any symptoms. So 50% are incidental, but the classical triad is loin pain, hematuria, and abdominal mass. So if there is abdominal mass, hematuria, just think of RCC. The pain can be there or not, but yes, the features, sometimes even if there is a cyst, we can't say it's malignant or it's benign, but the features that suggest it's malignant cancer, if it is solid, if it is solid plus cystic, it's mixed picture. And if there is any contrast uptake on CT, that suggests it's cancerous. But if it is just clear fluid, it's cystic lesion, then it can be simple renal cyst. Okay. So if the patient comes with loin pain, hematuria, abdominal mass, first investigation is ultrasound. In this case, patient already had an ultrasound. We go for four-phase CT KUB, which has four-phase arterial, and this. We don't have to memorize these phases, but just for your knowledge, first the contrast will go to arteries, then corticomedullary junction, and then whole kidney, and then the excretory system. So these are the four phases of CT KUB. Now the management. So renal cell carcinomas are quite aggressive tumors. So if the patient's life expectancy is less than 5 years, for example, it's a very old age patient who is having dementia, diabetes, hypertension, a lot of things, we just have to do the surveillance 6 monthly if the size is less than 4 centimeters. But if the life expectancy is more than 5 years, then we can operate. And when we are planning to operate, we have two options. First is partial nephrectomy, other is total nephrectomy. Preferably, when we'll go for total nephrectomy, if the mass is more than 7 centimeters, it's a big mass. So 7 centimeters, we have to remove complete kidney. Second, if the mass is in the middle of the kidney, so we can't just remove just the mass, because what will do the two portions of the kidney, so doesn't make sense. Central location. And if the mass has involved the lymph nodes, vein, arteries, adrenals, so if it has locally advanced cancer, we have to do the total nephrectomy. And in what case we'll be doing partial nephrectomy? If the mass is less than 7 centimeters, it's a small cancer, we can spare some part of kidney like this. If it is present bilaterally, bilateral tumors, we can't remove both the kidneys, we'll try to save some part of the kidneys. If there is a risk of CKD, we need that part of kidney that we can save. And single kidney, definitely, we just want some kidney in the patient. Okay, so don't remove everything unless there are indications. So this is the management. And if we are going for partial nephrectomy to remove the rest of the tumor or margin, we can go for ablation. The ablation can be the cold temperature, heat, RFA, the cryo, heat, and RFA ablation. So it is used in residual disease after partial nephrectomy, unilateral or transplanted kidney with RCC, and risk of multiple RCCs over lifetime. We can use this ablation technique because we can't operate every time the patient is having RCC. So yes. Now let's come to the boring part. Okay, so stay with me, and after we finish the boring part, I'll start with something more interesting. So stay. Okay. So hematuria, if a patient comes with flank pain and dark urine, dipstick is positive for blood. Okay, so tell me, if the dipstick is positive for blood, is it like truly positive, or can it be something else as well? Yep, tell me. Okay, so if there is a, uh, I'll be looking at your answers from my phone. So I'll ask Samir to, yeah. Mm, okay. Yes. False positive can be there in the cases of myoglobinuria. Okay. And how to, yeah. Okay. So if there is flank pain, hematuria, if it is true hematuria actually, so there can be three causes. The first one is malignancy, second is infection, third is stone. What do you think is the most common cause of microscopic hematuria, and what is the most common cause of macroscopic hematuria? Tell me. Yep. What is the most common cause of microscopic hematuria, and what is the most common cause of macroscopic hematuria? Okay. Stones, IgA, infections. Okay. Okay, so most common cause is urinary tract infection. So infection is the most common cause of both hematurias. Keep this in mind. Malignancies are not that common, stones are not that common. Infection is so common that it is the most common cause. Okay, so if a patient comes with the above symptoms, we have to look for the clues in the question. If the question says it is an old patient of 80, 70, and having loss of weight, loss of appetite, suspect malignancy. If they're saying the patient is having fever with chills or burning urine or altered sensorium, think of urinary tract infection. And if there is nausea, vomiting, severe pain going down to the groin area, think of stones. So most common cause is infection. And now read this stem. Okay, what is the first investigation you would like to do? Ultrasound, okay. Urinalysis, USG. Great. So this case is typical of urothelial carcinoma, the bladder cancer. The bladder cancer patient will present with gross hematuria without pain. So painless hematuria, always think of bladder cancer. It is a clinical like gem as well. Always keep this in mind. If an old age patient coming with frank gross hematuria without pain, most likely it's urothelial carcinoma. So first investigation should be CT and gold standard. Sorry, first investigation we should always confirm the hematuria with urinary MCS, and we can go for CT abdomen. But the gold standard is gonna be anyone? Gold standard? Cystoscopy, yes, definitely. Gurmeet, very good. So cystoscopy is the gold standard. So this is a case of urinary bladder cancer, and the investigation gold standard is cystoscopy, and treatment is intraluminal BCG. It's a bit weird, but yeah, BCG, the vaccine, we give it in the bladder side, so it helps with the cancer control. Okay, so as I told you, if there is gross hematuria with loin mass, urinary malignancy until proven otherwise. So first line investigation is CT. The second line is USG. If there is no mass, then you go for first line is ultrasound, then second line is CT. But if we are having mass, it's always cancer. So what are the risk factors for cancer? Age more than 40, smoker, chronic cystitis, pelvic irradiation, exposure to occupational dye and chemicals. This is a very good clue because this is notorious to cause cancers. Okay, so these are the fun liners Be very quick to answer these questions one by one. So, chemotherapy drug causing hemorrhagic cystitis. Anyone? Yes, the very good. Cyclophosphamide. Investigation of choice. This is easy. Investigation of choice for India associated stones. USG. Very good. Congenital absence of. This is a tricky one. Congenital absence of vas deferens. How to conceive? Let's see. There is no vas deferens. Yes. Yes. So it's gonna be artificial reproductive technique in which we extract the sperm and then go for IVF. Why? Because sperms are still there. There is no passage. So there is no road, but the cars are there. So we have to get the car and do artificial reproductive technique and conceive. Okay. So the sperm extraction is the word you are looking for, or artificial reproductive technology, IVF. So these are the techniques. No surrogacy is needed because there are sperms. Microscopic hematuria is there in a question, and if there is microscopic hematuria, tell me how you will differentiate between whether it's glomerular or non-glomerular. Tell me. Yes, shape of RBC. Yes. So we'll be looking for cast and sediments. If the RBCs are crossing the glomerulus, for example, in glomerulonephritis, the RBC shape will be distorted, and there will be RBC casts. And give me a second. Want something? So yeah, sorry guys. So if the RBCs are crossing glomerulus, the shape is gonna be distorted because very thin vessels are there. So the cast will be the shape of the RBC will be distorted, and there will be RBC cast. But if it is non-glomerular, that is down below in the urinary tract, the RBC's shape will be intact. That is, it's just frank blood. So you have to differentiate like this. Oh, sorry. When do we need urgent surgical intervention in any case? So the answer for this is if the patient is having anuria or single kidney or bilateral obstruction or UTI with stones. So if there is a stone is there, and we have to do the surgical intervention as soon as possible if any of these conditions are there. Okay, this is easy one. Where do we see overflow incontinence? In what case? Yes, definitely. Very good. I forgot. Yes, very good. You guys are already prepared. Okay, so let's talk about proteinuria. In proteinuria, normally we excrete less than 100 milligram per day, and albumin is less than 20. Some books say 150. Just go with John Morthug. It says 100, so 100. And dipstick picks protein if it is more than 300. So it doesn't pick if it is between 100 to 300. So that's the drawback of dipstick. And when do we see false positive result in proteinuria? If there is alkaline urine and hematuria, the blood cell WBCs are there, it detects as protein. If there is mucus or semen in the urine, then it can also detect as protein. If a patient is having proteinuria, you have to suspect the cause. There can be two types of proteinuria. First is transient, the other one is persistent. In transient proteinuria, there are multiple factors. Exercise can cause it. Orthostatic, like patient is standing for a long time, then it can cause proteinuria. Pregnancy, UTI, fever, heart failure. Any of these conditions can cause proteinuria. That is transient. It will improve. But if there are two positive dipsticks over 1 to 2 weeks apart. For example, if a patient have proteinuria now and you repeat after 2 weeks and it's still there, it is persistent proteinuria. And then you have to go for urine microscopy and culture to rule out urinary infection, renal function test, electrolyte, and most important is urinary ACR, albumin creatinine ratio, or 24-hour urinary protein. Both these tests are almost same, but in 24-hour urinary protein sample, we have to collect urine for 24 hours. That is cumbersome. So random ACR is stat, you get to know the answer of how much protein the patient is losing. So that's good. Let's talk about CAS. This is a very important question because if the question says RBC CAS, WBC CAS, you have to make up your mind like what they are talking about. So RBC CAS, we already talked, is seen in glomerulonephritis. WBC CAS can be seen in pyelonephritis or also in glomerulonephritis. Eosinophilic CAS, just it is AIN, eosinophil AIN, or acute interstitial nephritis. And muddy brown cast. So brown shows necrosis. You remember by this. So muddy brown acute tubular necrosis, ATN. Hyaline cast can be normal or in AKI as well. Fatty cast can be seen in nephrotic syndrome, because in nephrotic syndrome, when we are losing so many proteins, we also lose protein that are bound to lipids. So there is hyperlipidemia that can cause fatty cast. So fatty cast, nephrotic syndrome. And when there is CKD, the kidneys are gone, there is VAX. So waxy cast. Whatever I said right now, it is just to make you guys memorize these casts and sediments. Okay, there is no logic, just to memorize. Some logic is there, but yeah. Okay, now read this stem and let's just get back to interesting stuff. Diagnose this patient. Yep, what's your impression? You can see there's some sclerosis on the X-ray, and there is chronic back. Age is 76. Yes, very good, Gurmeet. So the clinical impression here is prostatic cancer. First thing to do. Which bedside test you want to do? Yeah, we can go for PSA. Any clinical test you want to have a look at? Any clinical examination you're looking for? Yes, DRE, PSA we can send, and very good. And can anybody tell me the name of the score in prostatic cancer? We calculate the score after histopathology. Yes, very good. Harsimran, very good. So, okay, this is a clinical presentation of prostatic cancer. It is an elderly patient. If there is loss of appetite, loss of weight, or sclerotic bone lesions, or lower urinary tract symptoms, irritative or obstructive, we suspect prostatic cancer. And the next step is query DRE. Why I am not very confident with DRE? Because if there is prostatic cancer, the prostate will grow outside. It doesn't cause much of obstructive symptoms because initially it will start growing outside. So there are no in DRE we don't pick sometimes. Or and the other test we can go for is urinary, but sorry. So it grows outside, but the in BPH, benign prostatic hyperplasia, the prostate, the inner lobes are grown. So we palpate that on DRE better. Like the cancer is less likely to be palpated, but if it is palpated, there are some clinical features I'll be discussing later. So yes, the next test we can go for urinary MCS, USG abdomen, PSA, etc., etc. And the test PSA, when we do, the normal is less than 4. If it is more than 10, it is likely to be prostatic issue that can be prostatic benign prostatic hyperplasia or prostatic cancer, and if it is more than 20, it's likely metastatic. And in cases like where it is between 4 to 10, it's most of the times with BPH, but there are like 20 to 25% cases in which there can be cancer, but above 10 we suspect cancer. And we also go for bone scan if the PSA values are high, because there are high chances of metastasis to bones. And yeah, so bone scan ALP can give us some idea that there is any bony metastasis. False positive results can be seen in prostatitis, BPH, ejaculation, trauma, or DRE. After DRE, DRE is not very convincing, but some books say, some don't say. So nobody's gonna ask you just a question saying related to this, but it can be confusing sometimes. So, and to make the diagnosis, we go for transrectal guided biopsy, and we take two samples and calculate the score as per Gleason pattern scale. So one is small uniform glands and 5 is typical of cancer and how bad the cancer is. So you don't have to memorize this score, but you should know that there is a Gleason score. And as per Gleason score, we have to make up the management plan. If the Gleason score is, its minimum is 2, because there are 2 readings we have to calculate, so minimum score is 2. If it is 2 to 4, we go for radical prostatectomy. That means we remove prostate, seminal vesicle. So we remove prostate, seminal vesicle, and pelvic lymph nodes, and also bladder neck. So this area is removed. And if the score is high, it's 5 to 7, we go for external beam radiation. This is radiotherapy. And if it is 8 to 10, the patient will need androgen ablation. So there it can be due with medications, or it can be with medications or via orchidectomy. So yes. Now the situation is, if the age is less than 70 and PSA is less than 20, we have to go for, we go usually go for radical prostatectomy. And if it is locally advanced and it's an old patient involving seminal vesicle, we need 2 months of androgen ablation. Then we will go for EBR. Why? Because once we ablate the androgen, the growth of the cancer cell reduces, and it is better, there are better results after EBR. And if it is metastatic disease, we go for androgenic ablation, is bilateral orchidectomy. We castrate the patient, and it is gold standard. And the medications we use are sapropterin, flutamide, goserelin, and leuprolin. You don't have to memorize all the drugs, but you should have some idea like what this drug is for and like androgen ablation. And now we talked about prostatic cancer because that was the question. Now let's talk about BPH, which is benign form of prostatic enlargement. So this is the prostate, and it grows inwards. It grows inwards, leading to obstructive symptoms. So there are 2 types of symptoms. First is irritative symptoms. Irritative symptoms, that means bladder is irritated, and it causes urgency. That patient says like, I have to pee now. Nocturia, and he frequency that he goes for passing urine again and again. Obstructive symptoms are when patient tries to pass urine, he hesitates, and he intermittently passes urine after some time, and there is still some urine left in the bladder that causes post-voiding dribbling. And when the patient has to put so much pressure to pass the urine because there is obstruction, so straining. And when the patient is straining, it further compresses the pathway and there is a further obstruction. So yeah, incomplete emptying, decreased force of urination, the flow of urine will not be strong. Now let's compare BPH with prostatic cancer. No weight loss, marked obstructive symptoms, no obstructive symptoms. On DRE, the prostate is firm and there is a median sulcus between the prostate. that is palpable. But if the prostate is hard and median sulcus is gone, that means the question is talking about prostatic cancer. And elevated PSA with ALP, PSA values, these are the PSA values in prostatic cancers. But these values are not hard and fast. Just to give you an idea whether it's like BPH or PCA. Okay, so this is a DRE. We all know. What are the red flags in BPH? In prostatic enlargement, when we refer for urology, if there is hematuria, incontinence, retention, if there is retention, there's going to be hydronephrosis and then acute kidney injury. So these are the red flags. Bladder calculus or recurrent UTI. So we have to refer these patients to urology. Now treatment. Okay, guys, just let me know if you are tired. We can take a quick break of 10 minutes if you want. Yeah. Yes, good. Even I'm tired. I need some food. Okay, so we'll be taking 10 minutes break after this. I'll finish the treatment part. And yes, there are two slides. I'll finish these two slides. Then we'll take 10 minutes break. Okay, so let's just continue for two more slides. Red flags. Now the treatment. This is a typical question they ask. The patient is on prazosin or tamsulosin. What is the next drug? Don't answer same category drugs, because if there is if the patient is on tamsulosin and in question you see prazosin, you tick that and it's wrong. The next drug of choice is finasteride and dutasteride. These are 5-alpha reductase inhibitor. These help with BPH. So memorize these two drugs. These are the answer in the questions when they ask the second line drug. Next is surgical treatment. Most commonly we go for TURP, transurethral resection of prostate, in which we pass resectoscope and it rotates and clears the path to open the pathway. And the other less common procedures are transurethral needle ablation, incision of prostate, or laser ablation. You don't have to memorize these, but just to know. So last slide before break. TURP is the procedure we all know about. You have to memorize these complications. Not all of them, but what questions they are gonna ask from this slide is: the patient had TURP. What is the long-term complication? So long-term, most common complication is retrograde ejaculation. In 80 to 90% patients, there is a complication. Long-term complication is retrograde ejaculation. The other complications are erectile dysfunction. It can be temporary or permanent. There can be recurrence in 10% cases after 10 years. So this is also a complication, but it is just in 10% cases. But retrograde ejaculation is 80 to 90% patients. There can be UTI, bleeding, retention. Retention normalizes in weeks, and stricture, in when there is stricture, the urinary stream will be like spraying of urine, and the intensity is going to be low. Urge incontinence can be there. There is a typical syndrome that they might ask is TURP syndrome, in which when we go for tub, there is constant irrigation here. So when we are cleaning, we are constantly irrigating this area. So some of the fluid gets absorbed in the body, leading to fluid overload and hyponatremia due to absorption of irrigation fluid, and patient can get into heart failure. So yeah, let's just take a break, guys. 10 minutes break. It's 10 p.m. here, and after 10 minutes exact, I'm gonna start the next topic. Okay, AKI versus CKD. Then the last of the top slides are very interesting, very clinical. You won't be like feeling bored. So yeah, take a break.
Of the presentation.
Okay, so we are back.
Yep.
Let's just wait for other people for 1 more minute. Meanwhile, I'll just tell you guys in the end of this slide, uh, in this presentation, we have contact number of Samir, our course manager. So any of you guys want to join our course, just talk to him and be a part of this session. And for the candidates who are already enrolled, we have like uh, around 40 candidates already enrolled with our course. So those candidates, when you attend the next class on 18th, ophthalmology class, just make sure that you mention your name that you have registered with, so that we can enroll, like let you enter in the same class. Okay. And yeah, so we already have a WhatsApp group for the AMC preparation candidates. We can add you to that. And if you guys want to join our Telegram group, there's my own page where we'll be sharing the recalls and everything. It's by dr_Gupta_LD. You just search it and you can join that Telegram group. AMC by Dr. Gupta is on Instagram. For AMC preparation, we'll be posting some educational reels on that, some important topics, but the main topics we'll be teaching in our classes. So don't have your high hopes very high. Okay. And for that, you have to join our course. Okay. Uh, I'll share, Samir, can you share your contact number here? If anybody wants to join our course, they can
Sure, sir.
WhatsApp you.
Sure.
Yeah, just type it in the message box.
Sure.
And I think we can pin that comment if that's possible. Okay, guys, let's just start the session again. And with no further delays, we are just 20 slides behind. In 20 more slides, actually 19, we'll be finishing the presentation. Okay, let's just talk about acute kidney injury versus CKD, the medicine part. AKI is acute insult to the kidneys, leading to deranged renal functions. And the most common cause is acute tubular necrosis. Can somebody tell me what type of casts you see in ATN? Yes, very good. Muddy brown and granular casts. Very good. So acute tubular necrosis, there will be brown necrosis. Good. So the other thing is oliguria. When there is an AKI, there are chances the patient goes into oliguria. So if the urine output is less than 0.5 ml per kg per hour, some books says 0.3, but it depends on question to question or the scenario. So you have to remember like 0.5 ml per kg per hour. So for example, if a patient with weight of 60 kilograms, he must pass 30 ml urine every hour. And if that patient is not passing even 100 ml, that in 24 hours, that means the patient is in anuria, and that anuria is an indication of dialysis. We'll be talking about later. So we have this classification for AKI called rifle classification, in which there is risk, injury, failure, loss, and stage renal disease. You don't have to memorize this, but just for a rough idea, if the creatinine is increased by 1.5 times, it is risk. If it is 2 times, then injury, and then if it is more than 3 times, then failure. And we can also assess the kidney injury by urine output, as we discussed earlier. If it is less than 0.5 ml per kg per hour for 6 hours, it's stage 1. If it is for 12 hours, stage 2. And if it is less than 0.3 ml for 24 hours or anuria for 12 hours, that means it's stage 3. And if the renal, so you don't have to memorize this, just to go through this, go through from this slide, and you'll be good to go. And if the renal dysfunction is there for more than 3 months, that means it is a case of CKD. And the most common cause is diabetes, because diabetes is everywhere. And what are the indications of dialysis? These are AE-IOU, anuria, electrolyte abnormality, ingestion of toxins, refractory edema, and uremia. So uremic encephalopathy, uremic pericarditis, we have to go for dialysis. And some people get confused with electrolyte abnormality. If the potassium is 6, you don't go for dialysis unless the patient is already on maximum medical treatment and not in any acute dire condition that needs dialysis. So patient is already on medical management and still these complications are there, then you go for dialysis. So yeah, and now let's talk about AKI again. There are three types of AKI. One is pre-renal, the second is renal, and the third one is post-renal. So pre-renal AKI is when there is not enough fluid in body to perfuse the kidneys. That means shock, hypotension, sepsis, blood loss, anything that is hampering the blood to come to kidney from here. So that is pre-renal. So any of these causes, if we treat these things, the kidney injury will be reversed. If the patient dehydrated, give fluid, and etc. And the second is renal causes. Renal causes is here. The kidney is injured because of kidney injury. So glomerulonephritis, vasculitis, drug, toxin, inflammation, infection of kidneys. These are the renal causes of acute kidney injury. We have to treat these causes to correct the kidney injury, acute kidney injury, AKI. And the post-renal are from here, the pelvis to meters. So if there is any stone, any prostatic enlargement, any stricture, any cancer, whatever, any phimosis, paraphimosis that's obstructing the flow of urine, that can cause post-renal. That is more towards urological conditions that can cause post-renal AKI. So just go through this stem and let me know what is the likely diagnosis. Yes. Okay, PSGN, iron, very good. IgA, Harsimrat, very good. Post-streptococcal, PSGN, IgA, IgA. Yes. So it is not PSGN, it is IgA nephritis, because look at the stem. This patient is having, so first of all, any confusion with glomerulonephritis? I hope there is no confusion with that. Good. So this is a 26-year-old male gentleman, AKI and rusty urine. So hematuria and AKI and proteinuria. Sore throat 2 days back. So he developed sore throat, and in 2 days he developed AKI, proteinuria, hematuria. This is a typical feature of IgA nephropathy, and this is the most common. This is the case of glomerulonephritis, and most common cause of this condition is IgA nephropathy. And how to differentiate between the two? Give me a second. I'll go to this slide. So how do we differentiate between IgA nephropathy and PSGN? IgA nephropathy is most common cause of glomerulonephritis in adults, and it is symphyngeitic. So patient is having sore throat, and then he developed nephritic syndrome. So this is IgA, but as the name suggests, post-streptococcal. So once the streptococcal infection has been gone, it takes weeks or months. So if the patient is having skin infection and after maybe 2 months or 3 months it develops glomerulonephritis, it is PSGN. If sore throat after 2 weeks, 1 week it develops, that's also post-streptococcal. So that's the difference. So in this, the next investigation should be ultrasound to look at the kidney status, what's the baseline, okay? And the gold standard we'll be discussing later. So this is a typical case of glomerulonephritis, as we talked about. We have three scenarios. First is acute nephritic syndrome. Nephritic is hematuria with dysmorphic RBCs, hypertension, and proteinuria. All three were present in our case. And the proteinuria is not very high, but it can be mild to moderate. But in nephrotic syndrome, there is massive proteinuria, and we lose albumin and clotting factors, and NSARCA is there. There is no hypertension because it's more like chronic thing. So this is nephrotic syndrome, and sometimes it's asymptomatic kidney disease as well in glomerulonephritis. So when we are talking about glomerulonephritis, we already discussed IG and post-streptococcal. Little bit more about post-streptococcal glomerulonephritis. Group A streptococcus type 12 and 49 are the most common like types that causes this condition, mostly in children, that too in Aboriginal and Torres Strait Islanders. So these are the local people of Australia, who were there. So if we compare to India, they are like SC ST kind of people. So these people stayed in Australia. They are the natives of Australia, and then all the migrants from different Western world, they came. So the people who were originally from Australia are called Aboriginal or Torres Strait Islander. So just to have an idea. So post-streptococcal glomerulonephritis, good long-term prognosis, and the diagnosis we go for group A beta hemolyticus streptococcus antigen. So don't get confused between GAS and GABHS antigen. If the question there is a GABHS antigen in the in the options, don't get confused. It's group A streptococcus only. BH is beta hemolyticus subclass. So ASO titer, C3, C4, anti-DNSP. So these are the tests. Other nephritic syndromes are ANCA, SLE, Goodpasture syndrome. Goodpasture syndrome, there is renal as well as pulmonary involvement. So the patient will be having cough, maybe hemoptysis, shortness of breath, along with the renal involvement. Anti-GBM antibody, glomerular basement membrane antibodies. So antibodies attack this area, and it happens. So the gold standard is biopsy. We take the biopsy, and there is precentric glomerulonephritis or sometimes IgG linear deposits. Now look at the nephrotic syndrome. So this is the typical look of nephrotic child. NSARCA is there. Urine is frothy. So severe proteinuria, low albumin, NSARCA, dyslipidemia, hypercoagulability. Why we are having dyslipidemia and hypercoagulability? Can anybody tell? Yes. Very good. Very good. So when there is protein loss, all the proteins are losing. So the factors like different factors that are there to stop the coagulation cascade in the blood vessels, they are also losing in the kidneys, and the proteins that are bound to lipids are also losing. So there is dyslipidemia, hyperlipidemia, hypercoagulability. Blood pressure remains normal. Sometimes it can be hypertension as well, but yeah. So more than 3 gram protein loss in a day, urinary ACR of more than 300. So if these criteria are fulfilled, it is the nephrotic range proteinuria. And the most common cause in children is minimal chain disease, FSGS, focal-segmental glomerulosclerosis, membranous membranoproliferative glomerulonephritis, diabetes, SLE. So in developed countries, in any question, if you are not sure, because there are going to be so many questions, and sometimes there are some questions you don't know the answer, diabetes is a very good option. So common, and it can cause nephrotic syndrome as well. So you can go with this option if you are confused. Okay, so there are SLE, amyloid, Hep B, C, HIV, malaria, cancer. So many causes are there. The treatment, just give diuretics, minimal chain disease, steroids are effective, and to stop the kidney damage, we go for ACE inhibitors, ARBs. They protect kidneys, and along with statins. So yes, I love this slide. So this is the slide differentiating between rhabdomyolysis and tumor lysis syndrome. So what is the difference between two? Rhabdo is muscle. Rhabdo is skeletal muscle and myo is muscle and lysis. So muscle damage is there. And in tumor lysis syndrome, the tumor cells are being lysed. So in rhabdomyolysis, muscle cell break due to trauma, crush injury, exercise, or sometimes elderly with fall. They just lie on the floor for 1 day, 2 day, and there is marked injury to the muscles due to dehydration as well. So there is a release of potassium, phosphates, myoglobin, and CK from muscles. So these are raised in rhabdomyolysis, and when the phosphates are released in the blood, they bind with calcium. So there is hypocalcemia, and this myoglobin will be released in urine, causing dark brown urine, which is not the case in tumor lysis syndrome. So differentiating point. And uric acid will be almost normal, maybe slightly higher side, but not very high. Contrary to that, tumor lysis syndrome cells break. It can be due to chemo. So when a patient with high cancer burden, we give chemotherapy, the patient can go into tumor lysis syndrome, or maybe spontaneous in cases with lymphoma, leukemias. They are notorious to cause TLS. So they also release potassium phosphate as rhabdomyolysis, but there is no myoglobinuria or CK release. But as the cell breaks, the tumor cell, there is release of uric acid. So it causes AKI due to uric acid and also calcium phosphate. Same scenario like rhabdomyolysis can also cause kidney injury. No myoglobinuria, uric acid is very high. So that's the case. Now, a little bit about dialysis. So there are two questions that they ask. Sometimes like the patient is having dialysis and there is hypertension. So what could be the causes of hypertension? When we are doing dialysis, we are removing the excessive fluid from the body. So when the fluid loses, there is activation of RAS system, reticular system, to maintain the high blood pressure, and it causes hypertension. And there is sympathetic overactivity, calcium and potassium or variation that can cause. Maybe there is not effective dialysis that can cause fluid overload, and so many theories are there that can cause hypertension. And so the treatment is we just increase the duration of dialysis so that it is slowly controlling the hypertension. And also when we are doing dialysis, the medication to control hypertension are also removed sometimes, so that can also cause hypertension. The second situation is when the patient is in dialysis and maybe post dialysis, there is hypotension, the blood pressure goes down. It is a common complication. Most common causes excess dialysis, we remove too much fluid. So, and the other option can be allergic reaction to dialysate, the solution that we are using in dialysis machine. So it can have, the patient can have V's dyspnea, so we know that it is allergic. So we treat accordingly. The pattern is episodic with cramps, vagal symptoms, maybe electrolyte disturbances can cause all this, cramps, yawning, different symptoms, and persistent chronic with soft blood pressure. So these are the two patterns. You don't have to memorize these, but when you'll see the question, you'll know, okay, this is the answer. So that's why I included this topic in my lecture today. The other option is that this, we were talking about hemodialysis, but let's talk about peritoneal dialysis, in which we put dialysate in the peritoneal cavity overnight and then remove with the waste in it. Okay, so when we are having peritoneal dialysis, there are high chances of peritonitis. So there, because it is an invasive procedure, there can be skin contamination, skin bacteria that can go in peritoneal cavity from this opening, or maybe some bacterial growth on this line. So line associated infections can also come. To diagnose this, we take the ascitic fluid sample and calculate the cells in it. So if there are more than 100 WBCs or more than 50 neutrophils, it means this is peritonitis. Can somebody tell me? Okay, after this. So we go for gram stain and culture and cells. And if the cells are more than 100, it's with neutrophil counts more than 50, it is peritonitis. Even if the cells are less than 100, but neutrophils are more than 50, still it's peritonitis. We have to treat that. And if we go for amylase and lipase, that will be normal in this case, but in cases of secondary bacterial peritonitis that we see in CLD patient, chronic liver disease, that is high. Okay. Now the question for you all is, what are the number of cells that we see in CLD patients, to call it second spontaneous bacterial peritonitis, SBP? What is the number of cells and neutrophils as well? Tell me. Yep. Anybody? Very good, Deep. So WBC count more than 500 and neutrophil. Very good. So more than 500 and 250 neutrophils. That's SBP. But in this case, it's just 150. So just remember this, okay? Now we are coming to the end. So easy topics. Incontinence. There are different types of incontinence. In this slide, we'll be discussing about stress and urge incontinence. So if a person comes to you saying that, Doc Saab, whenever I'm sneezing or I'm coughing, I leak some urine, what is the what type of incontinence that is? Yes, very good, Jomin. So that is stress. Sometimes we are lifting heavy weights and we pass little bit of urine. That is stress incontinence. It is due to the weak pelvic muscles. The history will be there is history of vaginal delivery or obstructive labor. So the muscles become weak. And in this situation, we recommend Kegel exercise. This is the Kegel exercise, and 3 sets, 8 contractions for 8 seconds, just to make you memorize. Otherwise, we can go for 8 to 10 contractions, 8 to 10 seconds for 3 months. So this is the exercise to make the pelvic muscle strong. The other situation is urge incontinence. So there are some patients who will come to you that, Doc Saab, whenever I'm feeling like passing urine, before I reach the washroom, I pass little bit of urine, and that is definitely Nadira. So that is urge incontinence, because there is an urge, and before we reach the destination, we already passed little bit of urine. So that is because of detrusor overactivity or instability. So the bladder is very active. That is urge incontinence. For this, we have to tell patient to take notes like bladder training. We have to make a diary mentioning like, okay, when I pass urine and when I next time I open your pass urine. So we have to make it every time we have to try to delay it by 3 to 5 minutes. We have to hold the urine, and then ultimate goal is to hold it for 3 hours between 2 episodes of passing urine. So if I am urinating now, I have to make sure that I pass urine after 3 hours, not before that. So that's the bladder training. But in any of the cases, whatever the case is, stress or urge, we recommend both the things together, Kegel exercise and bladder training. So that's the treatment. You don't say only one thing, because when we combine these two exercise with bladder training, the results are better. So definitely this thing will help more in stress, this will help more in urge, but little bit effect on the each other as well. Okay. And definitely there is mixed incontinence in most of the cases. So if there is no response after these treatments, then we have other options that we call surgical options. So first is for stress incontinence. There is tension-free vaginal tape, which is transcutaneous, mesh around mid and under around and under mid urethra. So they place a mesh to support the bladder and to make it stronger. It's like a mesh in that we do in hernia. That type of association is there. The other is Birch Kolper suspension, in which they put some stitches. This is intra-abdominal approach, and they lift the bladder neck to make it more supportive. And for urge incontinence, we have another option, that is anticholinergic and solifenacin, that make the detrusal muscle relax. Now, read this question and give me the diagnosis quick. Is it torsion or is it is epididymorchitis? Very good. Deep, you're wrong now. Okay, so the trick here is the Prehn test is negative. That means even if you're lifting the testis, the pain is still there. That means the testis is tangled, and no matter what you're doing, the pain is not going. That means torsion is there. So the diagnosis is torsion. And what is the next step? What you're gonna do? Is it gonna be an ultrasound or urinary test, or what is the next step? Okay, you guys are smart. Cool. The next step is OT, because in any case, without any delays, you have to operate the patient. You don't have to waste time in ultrasound Doppler to confirm, because this is a young patient. The book says in a patient less than 18 age, if there is scrotal pain, it's always torsion unless proven otherwise. So always go to OT and open it up and see what's going on. Why? Because this is a young patient, and if we delay the operation, after 4 to 6 hours, the test is gonna be gone. There's gonna be necrosis, infarction. So there are two scenarios with scrotal pain. First is torsion, that the case was. So Prehn negative, no improvement in pain, take to OT directly. If there is epididymorchitis, mostly in adults, STD is the infection that can cause the inflammation of the scrotum. So we go for ultrasound Doppler to exclude torsion with baseline investigations and chlamydia testing as well. So why there is relief of pain in epididymorchitis and not in torsion? As I told you, in torsion, the testis is rotated and tangled and there is no blood supply, so it's dying. No matter what you're doing, pain is not going to improve. But in epididymorchitis, the testes are inflamed. Okay, so testes are inflamed, and when you lift the inflamed testes, they feel relieved and there is some improvement in pain. That's positive Prehn test. Now, the scrotal lump. If there is a solid lump in scrotum, that means it is cancer, unless proven otherwise. Okay, so what are the risk factors for cancer? Cryptorchidism, the undescended testes. And if there are undescended testes, orchidopexy, that we have to stitch it back to the normal sac, testicular atrophy, past history of testicular cancer. These are the risk factors for testicular cancer. Now, what are the investigations we go for? First, go for ultrasound, because ultrasound is so good in testicular cancers, is so superficial. It can even tell whether there is invasion of tunica albuginea or not. And the next is send alpha fetoprotein, beta HCG, and LDH. Why these tests are important, we are going to talk in soon. Then go for CT abdomen and pelvis for staging. And we never go for FNAC or biopsy in testes. Why? Because there are high chances of spread. So never puncture the tumor in testes. In seminoma, there are all tests are negative, but in 20% cases, beta SCG is raised. So seminoma, only beta SCG is raised. But in non-seminoma, there are two things, non-seminoma. So two tests are raised, alpha fetoprotein and beta SCG. So we send three tests, alpha fetoprotein, beta SCG, and LDH. So if beta SCG is raised, most likely seminoma. If both beta CG and alpha fetoprotein is raised, then non-seminoma cancers. And if LDH is raised, that means it is some sort of metastasis is going on. Okay, and treatment is orchidectomy via inguinal approach, because we don't want to spread the cancer cells by doing incision on the scrotum. Next is testicular cyst. If there is a cyst, and you go for ultrasound, there is simple cyst. It can be tunica albuginous cyst, or retatastis, or intratesticular spermatovaricocele, different things. But 23% chances are there that the cysts can be malignant. So which test you want to do next to find out? UHE. We already did ultrasound. After ultrasound, what is the next test to diagnose whether it's cancerous or not? We can't do FNAC. Okay, cool. Yes. I wanted to hear tumor markers. We have many options. So we have many options. We already did ultrasound, but if we never go for FNAC in any sort of, because I already told there are high chances of spread. So no FNAC, no biopsy, nothing. What we can do is we go for alpha fetoprotein, beta HCG, and LDH. If any of these are raised, answer is there. Other tests can be CT if there is contrast uptake or anything. Then yeah. So next is infertility. So azoospermia is totally different from hypogonadism. Most of the people confuse these two terms. So if FSH, so FSH releases from hypothalamus pituitary axis, and FSH is increasing to stimulate the testosterone and the sex hormones. So if SSH is more than 2.5 times normal, that means there is irreversible testicular failure. That is azoospermia. And now there are two types of azoospermia. First is obstructive, that the sperms are being made, but there are obstructions somewhere. In those cases, FSH, LH, testosterone, everything will be normal. Just the path is blocked. But if it is non-obstructive azoospermia, that is primary testicular failure, in those cases, FSH, LH will be high and the testosterone will go down and testicular volume will be down as well. So hypothalamic pituitary axis is trying to stimulate the testes to produce sperms, but it's not producing. That's primary testicular failure. But in cases of hypogonadotropic hypogonadism, there is problem with brain. There is no FSH, LH that is being produced. So everything is low in hypogonadotropic hypogonadism. Okay. The other test we can go is ultrasound, inhibin A, antispermin, antibody, LH, chromosomal analysis, because there are so many diseases that can cause infertility in males. Okay. So, and this is the concept I wanted to tell you guys. If the question says there can be some different stems for the same question, but the result of that stem is the inguinal lymph nodes, they don't drain testes. So in testicular cancer, never look for, like, don't assume that the inguinal lymph nodes will be enlarged, because these lymph nodes drain the area, skin from buttocks, thigh, leg, scrotum, penis, but no supply from testes. So inguinal lymph nodes are spared. And how the drainage system is there? They like the drainage supply from testes is from gonadal vein, in retroperitoneal lymph nodes, para-aortic lymph nodes, thoracic duct, and mediastinal and left cervical base of neck lymph nodes. So if we have lymph nodes here, that means it's almost in the systemic circulation and it is the worst prognosis. So that is the last stage of, like, when the cancer has already been spread. So don't expect that the inguinal lymph nodes will be enlarged. So yeah, that's all, guys. And I hope this webinar, this session, this demo class helped you, and it was good enough for you to prepare for MC1. And this is Sameer's number. If you want to enroll in our course, You can contact him, you can WhatsApp him or call him directly. He's happy to be bothered. And the next class is on 18th, being taken by Dr. Shukla. It's the ophthalmology class. So just be there. And yeah, that's all. And just give me the feedback. Yeah. So give me the feedback in your comments. How was the class? What could be improved?
Now all the students can switch on their mics.
Yeah. Yes, Mansi. So okay, first of all, I'll stop stop sharing. Okay. Is it stopped? How to stop screen sharing? Yes. Yes. Cool. So yeah, the notes will be provided to the people who have joined our course, but this video will be available online for some time so that other people can see and have an idea what type of coaching we are providing. And can we also get, we'll be providing recalls and study material. See, the purpose of this coaching is to make you guys clear AMC1 and get you here, because I myself left India after doing MD medicine, and I'm happy in Australia. So why you shouldn't do the same? Like, if you want to, I'm happy to help. And all my mentors are very keen to answer your questions in the groups and help you solve questions and give you tips and tricks how to pass the exam. And I'll be also taking some webinars in between the classes. This is a 3-month course. So within a month, I'll be taking a webinar with all my students and interacting one-to-one, asking their questions, like what sort of problems they're facing, because this is not a difficult exam, but this is a tricky exam. And if you don't know how to answer the questions, you're not going to pass it. Okay. So the coaching is for 12 weeks. We will finish the syllabus in 12 weeks. There will be 2 classes mostly on the weekends, but I might add 1 or 2 classes in some weeks to cover the syllabus or give you some tips and tricks, and just to keep an eye how you guys are doing. So yes. Yes. Anybody has any questions? You can ask directly. I have 10 minutes.
Excuse me, sir.
So, very good evening.
Good
Will
evening.
we be provided with notes that are online PDFs or hard copies?
See, I'll be providing online the presentations we are presenting. We'll be providing you those presentations that are enough, but you can always, for next classes, we'll be providing you the presentation beforehand so that you can add your points in that. But yeah, I prefer if you make your own notes. Okay.
Sir, do we need to read John Murtagh or AMC Red Book,
No.
or the notes are enough?
No, you don't need to read John Murtagh, because we are covering John Murtagh in our classes. Most of the topics are being picked from John Murtagh and recalls, and we make our own notes. But if you still want to go through the detailed version of some topics, for example, there are questions from colorectal carcinoma, they always ask, and you have to read that topic again and again. So in our notes, you can add few more points if you are free, if you are very keen. But we will be covering most of the things so that you pass. Our purpose is to make you guys pass this exam. Okay.
And sir, for MCQs, which platform should we prefer, Amadex or M+X?
See, I used Amadex, and that was good, but we are already providing you, but for your own practice, you can choose any of those platforms. But don't forget to do Blue Book. You can practice your questions there. And we're also developing our own question bank. Hopefully in couple of weeks, we'll be done with the question bank. Dr. Shukla is already working on that question bank, and we'll see what we can do.
So will it
Thank you
be a
so much,
paid
sir.
question bank or free?
Let's see. We'll be giving you some questions. We'll be conducting 3 mock exams. 2 semi and 1 full mock exam. So that will be free. That will be in this coaching. But if we are developing some proper question bank, that will be paid.
Hello, sir.
Hello.
Great class. Sir, I want to ask, like, there's a difference between what we have studied for our NEET PG and AMC. So
Yeah.
we can, like, everyone, us can see the difference. So basically, we read a lot in NEET PG preparation, and
Yes.
what you just taught us was very concise and
Yes.
accurate. So we have to do just that because we have to change our habit, actually.
Yes.
That's why.
NEET PG is, I prepared for NEET PG and I prepared for AMC 1. So the difference is in NEET PG, there is so much competition and the coachings are making it more difficult. They are teaching you the stuff from super specialty coachings as well, just to make you realize that, oh, this coaching is teaching us everything. But
Okay.
I cleared NEET PG just with the test and discussions and self-study, because the key to pass any exam is to know the pattern, know the tips and tricks, and reading too much and too much content is going to fail you.
Okay, sir.
Sure.
So, sir, after this class, we can do our recalls and questions
Yes.
from Blue Book. That's it.
Yes, yes.
Yeah, and
Definitely.
if you want to read more, then we can read it from the John Murtagh.
Yes. So
Okay.
John Murtagh, you don't have to read everything, but just in case, for example, if I taught this class in nephrology and urology, and you're practicing in Blue Book, and you see, okay, I'm not getting the answers for these topics, for example, renal stones, and you're confused, and you have made your own renal stone notes, and your questions are not being corrected, and then you can open the John Murtagh to read the complete topic, so
Okay.
that, because these notes are crisp and concise, so that you can revise just before your exam as well. But
Okay.
if you're
Sir,
reading
yeah,
John Murtagh, you
continue.
add
Sorry.
few points if you want to.
Okay. So, how can we use Blue Book? The Red Book and the guideline PDFs that we have, acquired from some of the Telegram pages.
Yeah.
Do we have
So
to use them?
Red Book is a very thin book. We'll be teaching that. We will have separate session for that, and Red Book is the content is not very much, so the one session will be more than enough. So we'll be covering everything, but just in case you want to read, you can read, but there's no need.
Will
Okay,
you
sir.
provide the Blue Book
Thank you.
PDF as well?
Yes, we'll be providing all the PDFs.
The Blue Book, you were
Yes,
talking about.
Blue Book, Red
Okay.
Book.
Okay.
Dr. Shukla is in charge of all the MCQs, so don't worry. He's the admin of that WhatsApp group, and we got you guys covered.